strapping in for a very clinical run through quite a complex area in endocrinology, managing pituitary tumors during pregnancy. Our mission really is singular. We want to unpack the latest guidelines, drill down into the evidence, figure out what optimizes maternal-fetal outcomes, and honestly confront some of those critical, sometimes pretty tough treatment decisions that define neuroendocrinology practice. We've got a good stack of sources here, and we're planning to pull out every essential piece for your practice.
Yeah, and this is definitely a high-stakes topic, even if the overall incidence isn't sky high. Pituitary tumors, and we're mostly talking prolactinomas here, they often cause hypogonadism, they impair fertility to begin with, but the real complexity just explodes during pregnancy. The sources really stress that the pituitary gland itself naturally gets bigger, hypertrophies, undergoes this lactotrope hyperplasia, all because of the massive estrogen stimulation. So if there's already a tumor there, you basically have this ticking clock for potential mass effect or, dangerous hormonal hypersecretion.
And something that immediately jumped out from the research as a huge and maybe avoidable problem is what the sources are calling the practice gap.
Hmm.
It seems we just can't afford to manage this reactively. We really need to be proactive. Every clinician really should be interviewing patients who have pituitary tumors about their family planning before they even conceive. The goal is clear. Get that definitive, successful treatment done first. Mitigate those known risks before things get exponentially more complicated during pregnancy.
Right. Let's start where most of the action is clinically. Prolactinomas. They're the most common pituitary adenomas by far, often showing up in reproductive age women. And, well, hyperprolactinemia is the classic fertility issue here.
Okay, most common, yes, but the risks during pregnancy seem dramatically different depending on the size, right? We're already dealing with the pituitary getting bigger naturally, but then you look at macroprolactinomas, the larger ones, and the sources say tumor growth happens in about 20% of cases during pregnancy. That seems concerning.
That 20% figure, that's the one that probably keeps endocrinologists up at night. It really should. And you contrast that with microprolactinomas. They show tumor growth in less than 5% of cases. That's a huge difference, like a fourfold difference. And it dictates pretty much our entire risk assessment and what we choose to do treatment-wise.
And the standard treatment we know is dopamine agonists, DA therapy, bromocriptine, or cabergoline, used specifically to get prolactin levels normal and, crucially, to shrink that tumor volume before pregnancy even starts. That initial shrinkage seems like the best defense we have. Case 1 in the sources really hammers this home, keep the DA going until you get maximum tumor reduction before conception.
Exactly. But now we hit that critical decision point. Pregnancy is confirmed. What do you do? The current standard, as laid out in the guidelines, generally says withdraw the DA therapy after conception. The idea is to minimize fetal exposure.
Okay, but let's pause there for a second, because this feels like where that dynamic risk assessment really kicks in. If the standard is just immediately stop the DA, especially in someone with a macroadenoma where we know there's a 1 in 5 chance it could grow and threaten their vision, are we just sort of choosing the lesser of two unknowns, fetal drug exposure versus potentially irreversible vision loss for the mother?
That really is the core clinical tension, isn't it? Immediate withdrawal aims to reduce fetal risk, absolutely, but it definitely elevates the risk of maternal complications. Now, if the patient has a microprolactinoma, withdrawal. Pretty straightforward choice, low risk. But for that macroadenoma patient, that 20% risk means you need relentless vigilance. Absolutely non-negotiable. The follow-up protocol has to be tight. The clinical follow-up every single trimester and monitoring prolactin levels monthly.
And it's just as important to be clear about what we're not doing routinely. The sources seem quite definitive on this. We are not just getting routine screening MRIs on everyone. MRI without contrast is kept specifically for when neurological symptoms pop up: severe headache, double vision, or the critical one, visual field defects suggesting the optic chiasm is getting compressed.
Spot on. And if those symptoms do show up, you have to act fast. Looking at the case studies again, specifically case 2, if a patient develops visual problems, say, in the second trimester after stopping the DA, you have to reintroduce the medication. Cabergoline is generally preferred, it tends to work better, and you can't just wait until delivery. Getting that DA back on board immediately takes priority over maintaining a completely drug-free pregnancy.
That really highlights how quickly the plan can shift, doesn't it? From just watching and waiting to immediate, pretty high-stakes intervention based purely on symptoms, not just some routine schedule.
Exactly. That distinction, watchful waiting versus immediate intervention, is really key as we shift gears completely now to acromegaly. Here we're moving from something common and generally manageable to a condition with dramatically higher stakes.
Right. This sounds like a much higher risk scenario overall. The sources connect uncontrolled, active acromegaly to some severe complications. arterial hypertension, gestational diabetes, and even increased maternal and fetal mortality rates. That really changes the primary goal, doesn't it?
Precisely. If you're looking at women with active acromegaly who want to conceive, the goal isn't just pre-treatment, it's aiming for definitive pre-treatment. Transphenoidal surgery is the recommended first-line therapy. You want to achieve control, maybe even remission, before conception happens. The aim is for the mother to enter pregnancy in the absolute lowest risk state possible.
And if surgery isn't feasible, or maybe it didn't lead to full remission, then medical management comes into play, either before or maybe even during pregnancy. So we're talking about things like somatostatin receptor ligands, octreotide or lanreotide, or maybe using cabergoline if there's also hyperprolactinemia involved. But I guess the safety of these during pregnancy needs careful thought.
Absolutely. And here's where we hit, honestly, one of the most surprising bits of guidance, especially for specialists listening. For acromegaly, normally we rely heavily on lab markers, right? GH and IGF-1 levels. But during pregnancy, the guidelines explicitly say routine evaluation of GH and IGF-1 is not recommended.
Wait, really? We just throw out the main anchor of how we usually diagnose and monitor this? Why disregard those specific labs?
It comes down to pure physiology. It's quite fascinating, actually. As pregnancy progresses, the placenta starts churning out its own specific growth hormone variant, the placental GH variant. And this variant stimulates IGF-1 secretion itself, leading to high IGF-1 levels, even in perfectly healthy pregnancies, let alone someone with acromegaly. So if we tried to track active acromegaly using those labs during pregnancy, we just couldn't tell the difference between the placental effect and a pathological recurrence. The data becomes, well, useless noise.
Huh. So we basically have to fall back on the old school method, just pure clinical vigilance.
Absolutely. That's exactly it. The focus shifts entirely to clinical symptoms. You're monitoring closely for any signs of mass effect like visual changes or headaches. And you're aggressively screening for complications we know are higher risk, like preeclampsia and gestational diabetes. If new, undeniable symptoms of mass effect pop up, that's the trigger for getting neurosurgery involved or considering intervention. Otherwise, you stick to symptomatic care and managing the obstetric risks.
Okay, so our final shift takes us to Cushing disease. Rarest pituitary tumor issue during pregnancy, but carries the highest overall risk profile. We're talking extreme dangers here. Highest rates of preeclampsia, gestational diabetes, even potential cardiac failure.
Yeah, and the diagnostic challenge here is arguably the toughest of the three conditions. You're trying to spot a potentially small recurrence of pathological hypercortisolism against this background of, well, naturally skyrocketing physiological cortisol. Cortisol levels normally spike during pregnancy anyway, thanks to estrogen and ACTH hypersecretion.
Right, that must make finding the actual pathological signal incredibly difficult. So what specific clues or parameters do the guidelines give us to try and identify a recurrence in this high background state?
The sources actually provide some fantastic, really specific numerical thresholds. They focus on late-night salivary cortisol, which seems to be highly sensitive in this particular setting, to even suggest a recurrence of Cushing syndrome during pregnancy. That late-night salivary cortisol needs to be elevated to 3 times the upper limit of normal in the second trimester and 5 times the upper limit of normal in the third trimester compared to the expected normal increases you see in pregnancy. Those factors, 3 times and 5 times, those are the key thresholds clinicians really need to remember.
Okay. Knowing those thresholds, if treatment is needed during pregnancy because the hypercortisolism is just too severe, maybe life-threatening, when's the window for intervention?
Transphenoidal surgery is still preferred if you need to intervene. And the timing is pretty specific during the second trimester. That window seems to strike the best balance. You avoid the risks of fetal organogenesis in the first trimester, but you also avoid the increasing difficulty and risk of pituitary surgery late in the third trimester.
But what if the hypercortisolism is milder? The clinical takeaway from the sources seem to suggest maybe a more conservative path.
That's correct. If it's mild hypercortisolism, it can often be managed with really intensive supportive medical care and close obstetric monitoring. You might be able to avoid intervention altogether. Now, for severe cases, especially if they're driving really difficult to control gestational diabetes or severe hypertension, medical options could include mifepristone. And in the most catastrophic situations, unfortunately, bilateral adrenalectomy might be the last resort needed to save the mother.
Okay. And finally, just briefly, what about non-functioning pituitary adenomas, the NFPAs?
NFPAs are pretty rare during pregnancy. And since there's no hormonal hypersecretion to worry about, the management really boils down purely to the mechanical risk, the mass effect. So surgery is reserved strictly for if neurological symptoms develop, which usually only happens if it's already a very large macroadenoma. Oh, and for all these patients, regardless of tumor type, we absolutely cannot forget the baseline hormone management, like adjusting levothyroxine doses based on monitoring free T4 levels. The demands of pregnancy drastically change those replacement needs. That's crucial.
Wow. Okay, so we've covered three very distinct clinical profiles there, and the
Yeah.
complexity in each one is, well, it's pretty astonishing.
It really is. And the synthesis, the main takeaway, has to be that individualized multidisciplinary care is just paramount, absolutely essential. We're constantly having to reevaluate the tumor status, adjust hormone replacements, make these really delicate decisions about surgical timing versus drug exposure. It's always this balance between controlling the maternal tumor, especially that irreversible risk of visual complications from mass effect, and minimizing the risk of fetal exposure to medications or interventions.
And we established that for prolactinomas, yeah, the standard is withdrawing dopamine agonists after conception, especially for the micros. But that evidence on macroadenomas, with that persistent, 20% growth risk, it just keeps bringing us back to that core professional challenge, doesn't it?
It absolutely does. The standard is clear. Immediate DA withdrawal after conception.
Yeah.
But considering that high rate of tumor volume increase, that kind of frightening 20% for macros, the question for future clinical refinement, the thing we need to grapple with, is this. How should endocrinologists and neurosurgeons potentially refine the criteria for maybe maintaining low-dose dopamine agonist therapy throughout pregnancy? Specifically in those select high-risk macroprolactinoma patients versus the current standard of just immediate withdrawal across the board, all with the aim of preventing irreversible visual loss. That, I think, is the cutting edge of the risk-benefit analysis we really need to pursue.
A really profound clinical and ethical challenge to think about as you review your next complex neuroendocrine case. Thank you so much for joining us for this crucial deep dive. We really hope this knowledge helps support and sharpen your practice.